Well, I thought I would sort of jump in and I guess, scroll down, that's the one. I guess I wanted to sort of set the scene as to why are we here? Why are we talking about lymphedema when this is a wound rescue day? And I guess I just wanted to set the scene by saying it's 3 o'clock on a Friday afternoon. Mrs. K, she walks through the door to the treatment room and she's here for her twice weekly dressing change. And you start to talk to her about her grandchildren, how was the graduation, and because you know everything about her. You've been seeing her twice a week for the last 2 years. And she's that patient that we all wish we knew how to help. We feel hopeless, powerless, and we want to improve things but don't know how. So she is a 77-year-old lady with right leg swelling. She has a chronic leg ulcer with ooze and it's odorous and nothing seems to help the ulcer get better. No fancy dressing seems to improve things. She has a history of melanoma removed on the right side and some lymph nodes removed from the right groin. And you're starting to wonder, maybe it's the swelling that's the problem. Maybe that's what's making things harder here. And she's the reason you're here today. We've all got a patient or someone similar to Mrs. K, and that's why we're going to take a closer look at lymphedema, and there's her leg. So we'll move along, and really the best way I thought is just plunge straight in. What is lymphedema? What is it that that we're talking about? And really, it's a manifestation of lymphatic insufficiency. It's when the pressure that's put on the lymphatic system is too much for the actual capacity of the lymphatic system to work, to be able to move that fluid away. And sometimes it's due to an overproduction of fluid, and so therefore it just can't cope with that volume. And other times it can be due to the fact that there's the same amount of fluid that everyone else has to deal with, but the actual lymphatics can't remove it fast enough, so the actual lymphatics are insufficient. And it can occur in any part of the body. And a lot of people in the general community have heard about lymphedema in the context of breast cancer and arm lymphedema, but most of us will see it in the legs and obviously with wounds as well. So if we keep going to better understand lymphedema, we have to know what's right with the body first. We have to know when the lymphatics are working properly. And so if we, so if we have a look at this diagram and we think, okay, what makes up the lymphatics? We've got lymph vessels and we've got the lymph nodes, and it all sort of comes back, and this is really the area I want to highlight here, the cisterna chyli, which most of us really have heard about once, and it's the back of the brain if we've ever heard it at all. And so really all these lymph vessels, they carry all the lymph fluid back to the lymph nodes, and then it drains into that central point, the cisterna chyli. And I kind of think of it like a balloon, a big sac in the middle of the abdomen, and everything drains back to that. And then it goes through the thoracic duct and tips back into the subclavian vein and back around the body. The fluid goes back around the body again. So just remember that cisterna chyli. If I remember to, I will refer back to it later on. But that's what I'm talking about when I mean the balloon in the centre of the abdomen there. This lymphatic system has to carry about 2 to 4 litres of fluid per day. That's quite a lot of fluid for this little system to carry, and I don't know if anyone's ever seen any dissections. It's really, lymphatics are very fragile, very transparent. There's really not much to them, and that's why they were missed for many years. I think really the lymphatic system's only been really known about for 30 or 40 years. It was missed a lot earlier on. People just cut straight through it. So really, it's got a lot to cope with when you say 2 to 4 litres, and it's moving, waste products, proteins, infection-fighting cells. It's so important for those immune reactions for us to be able to fight. And if I look, here we go. If we look closer at actually what goes on before those lymph vessels, there's superficial and deep lymphatics, and they're really quite fine. They're sort of at a microscopic level. And so if you look at where the fluid comes from, firstly, we all know blood goes out via the arteries, comes back via the veins, but not everything comes back with the veins. A decent proportion comes back via the lymphatics, and so that's more the protein infection fighting part of it and the waste products. So when it has to get from the capillary network, really at that interface between arteries and veins where the fluid's going out and coming back in, it's got to get into the lymphatics. And it uses Starling's principles, osmosis, oncotic pressures. This all kind of sounds vaguely familiar from sort of physiology days. I'm getting a lot of blank looks, aren't I? So really, I don't want to spend too much time on that because it's not going to really help us in the real world, but just knowing that it's these pressures that are bringing the fluid back into these vessels. And if we have a look at the next one, maybe, yep. it's this sort of microscopic level, these little lymph sort of capillaries or lymphangions there that the fluid's got to come back into, and it works via these changes in pressure shifts, but also by muscles. When the muscles contract, they open up. There's little microfilaments that attach and they open up a little bit, letting the fluid come in as well. So there's a couple of different ways. It's quite a complex, clever system. Of course, I love it, so I would think it's clever. But that's how the fluid's going to get in. And then once you'll see here, there's all these superficial ones that are just underneath the skin, and then they get to bigger ones, run deeper, and then we'll head back to a lymph node. And then this is where sort of the main immune response happens. I mean, we've all had a sore throat where we've got lymph nodes that have come up in the neck. This is basically what it's designed to do. And it's when this goes wrong that we get into trouble and we start talking about lymphedema. I don't want to miss anything, so I'm going to keep turning this and probably never look at it. So what happens when it goes wrong? Traffic jam, there's no other way to think of it. This is exactly what happens. And when you've got that load on the lymphatic system, when that's more than it can cope with, that's when you get the traffic jam. And I think town planners, when they work out how they're going to set up a city, and if we had, I think Melbourne planned this better than Sydney did, but when you look at how you've got to structure it, you say how many cars need to be on the road, how wide does the road need to be? And obviously if you've got a road that's only meant to fit 2 cars down it and you're trying to put 6, 7 wide down it, it's not going to work. And this is what is happening with lymphedema. We've got more fluid than the capacity of the lymphatic system to carry, and if you're standing at the back of the traffic jam, there's nothing you can do. No amount of pushing is going to change things. So, and we don't have the luxury of building a new road. This is really sort of where it all goes wrong. And you can get swelling in the arms, the legs, the head, neck, the genital area, really anywhere that the lymphatics might be affected. And then we talk about, well, what types of lymphedema then are created. When it goes wrong, you get lymphedema. What types are there? Primary and secondary. And that's what I just want to quickly run through. It's not, once you've got lymphedema, the treatment is going to be fairly similar between them, but it's sort of interesting just knowing where the types sort of come in. Primary lymphedema. So this is usually congenital. It can be present from birth. Puberty is often when it develops, when that sort of, I guess people might be outgrowing their lymphatic systems, when they sort of find later on in life, if there's a strain stressor again, women are often affected sort of in the 40s, or actually around childbirth is often a common time again to be affected when that extra load is on the lymphatic system. And let's face it, a baby right there, exactly where that little balloon I referred to, the cisterna is just altering pressures, all of that changes. And certainly later on in life. So you can have the congenital form, you can have the precox form, you can have the lymphedema tarda form, and they all just develop at different stages. So you don't have to be born with it. Obviously in this picture here, the gentleman is primary lymphedema. He developed it later on in life. I think this one he was developed in his 50s. But I might have that wrong. And then obviously this little guy has it in both arms, leg and trunk. And he had it from birth. I think he already had it in utero. And this lady with primary lymphedema, again, I think she developed it sort of late teens, and it's affecting her right leg there. Secondary lymphedema. This is the one that people are a little bit more familiar with, and certainly the different causes. So cancer treatment is where we hear about it the most, and this is because most commonly a lymph node's been removed, and obviously in the breast cancer scenario that a lot of people hear about having a complete axillary clearance, there's no lymph nodes. Where is the fluid going to go? We're getting a little bit better in that we're doing sentinel lymph node biopsies, or we're only removing part of the lymph nodes, so things are improving, but people are still developing lymphedema, and that's because it can be still due to the surgery, radiotherapy. That really does cause a fair bit of fibrosis and blockage of those superficial lymphatics. Remember that diagram I showed with the lymphatics on the top? Radiotherapy on top just fries those, it just can't move through. Chemotherapy causes a massive fluid shift, which even though a lot of that fluid shift is temporary, it's still putting that load on the lymphatics, and often with the lymphatics, once you tip it, it's very hard to get it to go back. So that's sort of the cancer side of things. Trauma, burns, we see really often with that sort of that tissue damage. Any other form of surgery really that's cutting through a lot of lymphatics or causing a lot of scarring, that can affect it as well. I've had a patient that had right leg lymphedema after an appendectomy. And you sort of think, well, that's pretty straightforward. I mean, it was a complicated one, there was a bit of infection involved, but that's what damaged the lymphatics. And I would argue that that person probably had a predisposition. Maybe they would have developed congenital lymphedema later on, they would have had that primary lymphedema, but they were sort of somewhere in the middle, and obviously that appendectomy was sort of their trigger. If we look at venous disease, this is where we're seeing a lot of ulcers, and really if someone's got insufficient veins, they're struggling to bring back the fluid. Where's that fluid going to go? It's going to sit there and it's going to put pressure on the lymphatic system, because the two of them, they're partners in crime, right? Like if they're not working together, the fluid's not moving. So usually if the venous system isn't working sufficiently, you'll find that the lymphatics are being overloaded, and there's often a combination edema. And here in Australia, we still talk about venous disease and lymphedema as very separate things, which they are. But in the UK, they're already starting to talk about, guys, just edema. It's all edema, it's mixed edema, as long as there's not anything dangerous there that's going to be like compromising the arteries. Really, it doesn't matter how you treat it, because it's all causing the same problem. We've got swelling and it needs pressure. So I think that's an interesting change, and we'll see whether that comes to Australia or not. I think give it time. Infections is a really big one. Obviously, a lot of people know about getting infection in the context of lymphedema. When you've got all that fluid there, it can trigger an infection, or it's more vulnerable to infection. But infection itself damages the lymphatics. Every time someone gets cellulitis, the lymphatics have to work harder, and it can damage those little superficial lymphatics there. So then they're more predisposed to getting lymphedema and further infections, and the cycle continues. Quite commonly, I have people that sort of, again, on that borderline where they're sort of vulnerable to getting lymphedema, and they get a leech bite or a really bad, that I think the bull ant's the classic one in Australia, where they get really severe bite, everything flares up and the lymphatic system can't cope, and it just won't go back to what it was before. The traffic jam's created and it's all come unstuck. So that's a big one. The other infection I've got there is filariasis. Say that one quickly. So filariasis, this is actually the biggest cause of lymphedema in the world. Obviously here in Australia we don't have too much of it unless you head right up towards the tropics. That's when we start to see it, and there's some really interesting research going up there with lymphedema and in the tropics. But here in Sydney, obviously it's not really on our radar, but in the World Health Organization, that is for them the biggest cause of lymphedema. The last one here that I wanted to talk about was obesity, immobility and dependency. And again, we see a lot of this in the older age group, in nursing homes, dependent edema, pretty common. And again, is it lymphedema? What type of edema do we call it? At the end of the day, if you've got swelling there, it's going to impact the lymphatics. It's sort of, the approach is going to be pretty similar. And either way, they're then vulnerable to infections and to wounds. I've just popped there factitious self-harm. Technically, that's when someone actually puts a tourniquet on themselves to actually create the edema. We don't see that too often, but just watch out for it. If you actually see a ring, they're doing it themselves. Just a couple of pictures. This is an example of lymphedema secondary after breast cancer, and this is what we're seeing, hopefully less and less of this as we get early intervention, and breast cancer, the McGrath nurses are great at intervening really early and recognising it, and now we're even doing tests on people after surgery to try pick it up before it even starts to swell. So to catch in the subclinical phase, but we still do have cases like this that need to be managed, and certainly when the swelling's been there for that long, it's quite hard to get that down, and eventually that swelling sort of turns into fatty tissue, and it can be quite hard to reverse. And this is an example of, just to highlight, men do get breast cancer, men can get lymphedema. So this is a gentleman on the right here who's got lymphedema in the arm, and on the left a lady with the lymphedema in the leg after melanoma surgery. This is a third type that I'm not going to spend very much time on, but just mention it really quickly, lipolymphedema. So lipedema is when lymphedema occurs as a result of it's an abnormal deposition of fat cells and causes edema in those fat cells, and it's more of a metabolic disorder, more common, it's almost exclusively in women, often hereditary. You might see it sort of going down the family tree, a certain type of shape to the legs. The edema tends to be from the ankles up and not affecting the actual feet, which is quite different to the usual presentation with lymphedema. But if you have lipedema long enough and the cells swell enough, eventually they'll block off the lymphatics. Thus, we're calling it lipolymphedema when they start to get swelling lower down as well. So just something to have on the radar, but not really certainly not a take-home message. This is what Gary sort of said I would tell you about. He said I'd say how common it was. So really, men, women and children, in terms of primary lymphedema, 1 in 6,000 is the statistics that we're being given, but again, more research is needed to be done on this. We need to update this, get more information, and really, as you can imagine, there's a lot of lack of diagnosis, so a lot of these statistics would be sort of underreporting it. In terms of the secondary lymphedema, with after cancer, we're sort of, some studies have looked at 20% of cancer survivors getting lymphedema, and I sort of think of that, I mean, that's what the data has suggested, and I sort of look and go, really? I'm not sure that we're seeing that much of it, but a lot of it's hidden, particularly lower limb, particularly genital swelling. People don't present with it, people carry on with their lives and try not to bring it up really. And we see particularly in the gynecological cancers, so cervical cancer, 24% go on with lymphedema afterwards, and that's because they often got quite extensive lymph node removal in the pelvis. Vulval, 47%. Melanoma, seeing we're doing the wound rescue thing here with the flags, the melanoma is 29%. So the statistics are quite high, and really, at the moment, they're quoting they're quoting about 300,000 Australians to be affected by lymphedema, and again, that's sort of an estimate done on population basis. We don't have that data solid because, again, it's not being recorded yet. So I'll come back to that. But that's sort of a watch this space. How do we recognise it? How do we know if a patient's telling us? I mean, a lot of us are going to be seeing lymphedema later, but if you do come across a patient that's talking about transient swelling, they say, look, sometimes the swelling's there, sometimes it goes away, I keep getting infections. Why does this person keep getting infections? Why do they keep getting cellulitis? Maybe there's some swelling there. Achiness, stiffness, heaviness, difficulty with range of motion of the joint if they've got swelling that way, feeling tight with certain jewellery, clothing, feeling warmer in the limb. All of these things really should say, no, go talk to your doctor about this. You need to find out more. And certainly worse at the end of the day. I mean, most of us have all had that, right? You just go out shopping all day and you'll get the swelling. But, you know, I think that if it's sort of, especially if it's not disappearing, that's something that's worth looking back into. Differential diagnosis. I just want you to have this in the back of your mind when you are seeing patients to make sure we're not missing anything really important. Obviously, DVT is the big one. When someone walks in with swelling on one leg, that's like the alarm bells. You know, and then they say they just got off a plane, and you're like, really? So, you know, the DVT is a big one to exclude. Baker's cyst behind the knee, when that pops, it's really painful, but also there's a lot of fluid. For a cyst that size, it's amazing how much fluid actually comes out and how much edema that causes in the leg. So that's a common one as well, and that sometimes is a mix up with the DVT diagnosis. CCF, so congestive cardiac failure, that's usually a bilateral edema there and a pretty important one to identify. The venous insufficiency, which we talked about a bit earlier, obviously dependency edema as well. The kidneys and liver, really important to just tick that one off. So again, that's why they need to go through their GP and make sure that there's nothing going on there. Thyroid as well. And there can be protein deficiencies that causes change in the fluid shift as well, which can lead to swelling. The other thing is medications. There are, you know, NSAIDs, calcium channel blockers, so some blood pressure medications will contribute to swelling. There are also some pain relief medications, so pregabalin is one of the ones that's known to do a little bit of that as well, and quite difficult because a lot of patients are going to have chronic pain issues with their swelling, so choosing the right medication for them is difficult as well. And steroids sometimes can exacerbate swelling too. So just having this in your brain somewhere just to sort of refer back to is helpful. How do you diagnose it? I guess the first thing to say is it's really a diagnosis of exclusion. So, you know, making sure we get through that list first and that there's nothing there that we should be dealing with. And don't get me wrong, there's often 2 things, 3 things going wrong. Occam's razor doesn't always apply. So that sometimes is a case of treating one so that you can see what's left and how much edema is left just purely to the lymphedema. But if we have a look at how you assess a patient, measurement, old-fashioned tape measure, really. That's often the way, you know, comparing arms, comparing legs. Obviously, if both of them are swollen, then that's not going to be so helpful. But taking a measurement is still important because you can compare week to week. You can compare how they're progressing with treatment. So certainly taking circumferential measurements. Bioimpedance. This is one that is... Gosh, it's probably applied like you would an ECG where you pop little stickers on little wires and you're measuring an electrical current. And the idea is that when you're going from A to B and you run an electrical current, it's going to move faster when there's more fluid there. So the tissues actually interrupt sort of the flow, but the more fluid there is, the faster it goes through. So when you're getting a higher reading, then it's more sort of edema there, and we use that more in the subclinical. So this is the one that we use when we're measuring people after surgery to know, or we actually start before surgery, so we know what their baseline is and then can monitor them and get them in treatment before it's actually getting to the point where it's a problem. Looking at skin changes, so looking for fibrosis, looking for thickening of the skin. These are all things that can occur, and eventually, once the fluid's there long enough, we know it gets really fibrotic, and we're actually now starting to see in studies that it's turning to fatty tissue, which is just quite not what any of us expected, but really that's what we're seeing, and we're doing MRIs and looking, and we know that when the edema's there long enough, it will convert to fatty tissue. So moving it, keeping the fluid moving is what's so important. In terms of what you can do at the bedside, the pitting test, we've all done the pitting test, right? You pop your thumb in, see if it indents, So traditionally they normally say lymphedema doesn't pit, then you know it's lymphedema. But that's when it's at the fibrotic stage. That's when it's not moving. That's when it's later on. So when you've got someone early, they might still be pitting. So don't let that throw you. That doesn't exclude the lymphedema. It just means it's still early on and you need to just check for other things still. Stemmer's sign. This is when, as that picture shows, just picking up at the top of the second toe. So I'm going to just on my hand so you can actually see it, but you should be able to do that with skin. You should be able to separate it and lift it up easily, but when you can't actually do that over the toe, that's when there's that edema underlying. So do it on yourself, at the beginning of the day, and then if you've had a really big day and your legs are swollen, you'll find it harder to pick up that skin. Blood tests, chest x-ray, Doppler, all of these things are really just knocking off those differential diagnoses. So just making sure that there's nothing wrong with the kidneys, liver, thyroid, making sure that we're okay from a heart point of view. Obviously excluding the DVTs. And the ultrasound CT, I've popped that there because in someone with a history of cancer, the tendency is to say, oh, right, swelling, yep, okay, you've got lymphedema. You don't want to miss a disease recurrence. You don't want to miss someone that's got cancer back in their lymph nodes and the lymph nodes are blocked off due to the cancer. So that's just really important that even though that's the most likely thing that they've got lymphedema and their lymphedema is due to disease recurrence, they need to make sure they're back at their specialist. So that's often a red flag for that one. Lymphoscintigraphy. This is what a lymphoscintigram is. It's when we inject dye to look at where it tracks. We pop it in, it goes in between the toes, or I guess in between the web of the fingers. It's incredibly painful. And the dye, what we do is we take pictures as it tracks through the body. And if you have a look, mouse, here we go. So this side is when it's been injected at the beginning and it's just sort of pulling at the feet. After an hour, it's tracked up. So up the left leg, there's a little bit happening here. And then at 6 hours, there's more. You can see where the lymph nodes are. You can see it's moving up and towards the liver and things like that. Nothing happening on the right side. Really not moving anywhere. And that's obviously the side that's got lymphedema. I've been a bit cheeky putting this one in here because this one actually has compromised lymphatics on the left side, so it normally lights up better than this. But you can still see that there's a difference between the two limbs. And so not everyone that has lymphedema has to have this done. This is more used in the primary lymphodemas, and it's more when there's a question of the diagnosis, but that's if someone talks about lymphoscintigraphy, that's what they've had. Just take a moment because it is really painful to understand that. This is a table that GPs find helpful to move through in the diagnosis. You're not meant to read that, and that's kind of like this is just a flowchart of how you can work through, but at the end of the day, we live in the real world. And the most important thing is rule out that DVT, make sure they're not in heart failure, check that the cancer hasn't spread, and just check that they've got good arterial flow, and obviously doing an ABI or a Doppler is the best way to check that. That's before you can ever treat lymphedema. I just want to know that none of those things are going on. So that would be my sort of take-home message on that one. Once we've got a diagnosis, what stage are they up to in their lymphedema? This is, again, not that crucial, but most of us, 0 subclinical, that's what I was talking about before, when there's actually no swelling. Sometimes they can be a little bit aware of it, but there's not actually anything to see. It's quite sort of subjective. Stage 1, bit of fluid accumulates, but disappears. Usually when they go to sleep overnight, they put their feet up, it disappears. Most of our patients will be stage 2 or stage 3 when the swelling is persistent, And stage 3 is when you're sort of seeing that elephantiasis type limb develop with that really sort of fibrous changes and that sort of skin changes. Complications that we see from lymphedema. So cellulitis is a big one, and I'll get back to that in a sec. Ulcers and the skin changes. So cellulitis, strep pyogenes is actually what we see the most of in lymphedema. So for that reason, we actually recommend using straight penicillin, phenoxymethylpenicillin as the treatment, and going for a good 2 weeks, not sort of doing just a 1 week treatment and hoping for the best. Even if it's improving, do the full 2 weeks. If you're seeing like sort of more of a folliculitis and sort of pustular changes, then that's probably going to be a Staph aureus and switching to more of a sort of a flucloxacillin for that. But that's probably, again, there's antibiotic guidelines on this, and what I'd be just saying is if you've got a patient that's getting recurrent cellulitis, you just keep seeing them come back and back, whether you're doing antibiotics in the home. If you're seeing a patient like this, question whether there's underlying lymphedema. Question whether they need to be on low-grade antibiotics long-term. They probably need some prophylaxis. This is a good resource. The Australasian Lymphology Association, they have antibiotic guidelines. It's a little bit different to therapeutic guidelines, and a lot of doctors aren't used to this, but it's a couple of pages document. But if you sort of keep finding that you're sending a patient back to, I can't believe I'm saying this, I'm a GP, but if you're sending the patient back to the GP and you're just not getting anywhere, and it's the same treatment and they're just bouncing, send them along with this document. They'll probably kill you, but send them along with the document, and that will give them a little bit of a new pathway to try. Ulcers and wounds. So obviously you're all here today to hear about wound dressings, and you'll hear a little bit more later. But really manage the wound. That's so important. I think from the lymphedema community side of things, we all kind of freak out when we see a wound. So we know how to bandage, but we don't know what to do with the wound. Manage the wound. Put a dressing on and bandage over the top. You still can do both. And I just thought I'd mention this product. I know they're not here today, but Mobiderm is a new product from Medical Rehab, and it's sort of got this foam built into a wrap device that actually puts pressure as well as moves and sort of massages the lymphatics around the wound, so it actually promotes a little bit more wound healing and flow of that fluid. So there's just other things to sort of be aware of and think sort of tools that are out there. These are some of the skin changes that you might see, and obviously fibrosis is that hard thickening skin there, we'll all have seen that. And hyperkeratosis as well, that's again sort of along those lines where it's getting thicker. But lymphangiectasia is what I wanted to highlight. This is when the actual the lymph vessel gets dilated, and it gets to the point where, I mean, look, that's going to pop, isn't it? And what's going to come out of that? Lymphoria. And that's when you've got that ooze, those dressings that you just can't quite get enough there to mop up, where you just sort of find that as soon as you've done it, it's already soaking through. Papillomatosis and elephantiasis, again, we don't see too much of it in Australia, but we've all probably had 1 or 2 patients in this category. And certainly this lady was having dressings at home. That's actually her husband that was doing her bandaging. The effect on people, what's happening with lymphedema, I mean, really the effect is mostly on their ADLs, isn't it? Their quality of life, and you know, they might have physical pain, depending on the degree of their swelling, depends on how much what their limitations are. Mental health, big factor. I mean, self-esteem, for a lot of people that have had the cancer journey, it's a constant reminder. I mean, people say this, I've had a life-threatening condition replaced by a lifelong condition that's there 24/7. So just be mindful of that when you are going through. We often see patients where you say, why are they neglecting their lymphedema? Why are they ignoring it? If that was me, I would be doing something about it. Sometimes that's what's going on at the back of their mind. This is the cancer journey, and they just don't want to deal with it again. Financially, we all know cost of dressings, cost of bandages, cost of garments, cost of not being able to go to work. So all of these things are a big impact, and then obviously what it's doing to their health, and bouncing in and out of hospitals with IV antibiotics. So really quickly, the lymphedema cycle. On the left-hand side is when someone doesn't have access to services, and they're really just continuing to go round and round. They develop their lymphedema, they get increases in swelling, they get the infection, the ulcers, the lymph fluid, the lymphoria, hospital, in more infection, as we know, increases the edema anyway, and then we just go round and round, and these are all the bits on the side we just spoke about. But if we get onto it early with diagnosis, we can get some education, we can empower them, we get them garments, a bit of self-management techniques, then this is certainly, we can get regular review, maintenance, and keep that swelling down and avoid infections. That's the goal. So this is, we just had our awareness month in March, so I'm still a bit riled up from that. This is how you treat it. And I really like this diagram because it sort of puts it in two phases, and really the key here is educate the patient. The patient is going to be, if they don't understand why they're doing something, they're not going to do it. Skincare, exercise, massage, and compression. And massage and compression are the biggest ones, compression being like if you do anything, compression is needed, but all of these things working together. And so if we look closer at this diagram, the blue side is phase 1, and so that's the initial treatment phase, and then the green side is the maintenance. And they're pretty similar. Each time, you know, both of them have got good skincare, both of them are doing exercises, both of them have massage, and sometimes the massage is done by a therapist, sometimes it's done by the patient or a carer. And if you're in the maintenance phase, obviously the patient can keep doing it at home. But the difference is just with compression. And initially, the bandaging is the first phase because you can keep adjusting the bandaging. If you bandage every day, it'll get smaller, and then you do the bandages again, and it'll get smaller. Whereas a compression garment is just going to maintain. It's just applying the same pressure every day. So it hopefully won't get bigger, but it's certainly not going to get smaller by just wearing the compression. So just kind of keep that little diagram in mind. In terms of education, avoiding the risks. I put here the controversial ones: blood pressure, blood tests, vaccinations, and flying. The evidence is coming through that really these are not that severe as we first thought. Initially, when people had surgery for breast cancer, we said, do not do any of these things ever. And we now know that it's probably can be a little bit more lax with that. But essentially, if you've got another arm that you can use, then you know, why wouldn't you? So these are the things that you sort of still can advise patients, but just perhaps it's not the Bible. And it's still important that people get blood tests done and they get their treatments. Just quickly, avoiding heat and saunas, that's a big one. Really, these patients should not be in saunas, spas. I think you guys know that already. And just avoiding increased in BMI, because that will just impact, again, on that cisterna chyli back here if you've got central weight gain. Good skincare, obviously washing regularly, moisturiser, because when those cracks develop, that's an entry point. Detecting those fibrotic skin changes early, and good nail care. And really, I mean, the simple stuff that you would do for a diabetic, you know, leg, that's the same kind of thing. Exercise. Again, in the past, people said, no, don't exercise, this will exacerbate things. But we know better than that now. And we know that actually exercise helps. It sort of moves fluid through, and you find that it will actually, yes, when you exercise, you get increased blood flow to that limb, but the muscle is contracting and pushing that fluid through both the venous and the lymphatic system. And so my take-home advice is just, yes, advise your patients to exercise, but the cool down is really important. And that the cool down is because then if they've gone for a really long walk, just to do a really small movement of their legs afterwards, because that muscle will still keep pumping and move the last bit of fluid that was brought in by the exercise, move that away. And so rather than just come home from like a run and sit straight down with your legs down, that's just asking for the swelling to increase. I put breathing here with exercise because we obviously breathe when we exercise, and that is really changes in pressure in that intrathoracic region. Again, working on that cisterna chyli, and so you'll find that you're drawing that fluid out of that balloon there. And so when people talk about abdominal diaphragm breathing, that's going to move it there. So if we're all sitting hunched over and not sort of aerating our lungs properly, we're not going to move it. So most lymphedema therapists will actually teach the patient deep breathing exercises first. And you think, no, get to the leg. But this is the first place to start, because you wouldn't, that traffic jam picture, I actually don't know where that was from, but if you stood at the end and pushed, nothing would happen. If you move the first couple of cars, then you can start to move everyone through. So this is why you've got to start at that central point. These are the dragons of breast, and I think a lot of the research is actually done with them initially to say, yes, this is good, this is helpful exercise, it's not bad for you. But again, I don't row, I'm sure many of you don't row, and I'm certainly not going to advise my patients to start rowing. Some practical stuff, Just gentle walking, calf exercises. The same thing you'd say to someone on a plane. Don't sit there the whole time, walk up and down the plane. Just, stand at the back of the plane doing some of these. And I've got a picture of a push cush, because really it's a very simple device. And so if you've got someone that's isolated at home or in a nursing home and they can't really, or they're not mobile enough to go out for a walk, sitting a push cush underneath, it's really just a sort of a blown up device, and you just put pressure on one side and it pushes the air to the other, lifting up the leg, push the foot down on the other side, goes back up, and it's just encouraging that movement. So I'm sure we can all think of patients that would apply to. If someone is doing large amounts of exercise, get them to elevate their legs afterwards just to assist. I mean, this is gravity really. Make sure people are wearing their compression during exercise. I've got patients that say to me, oh no, I take it off while I exercise. And I'm like, no, that's the time you need it on, and afterwards as well, not to rip it off as soon as you're finished. And deep breathing, I'm back on that sternochyly there in the middle, and I think sometimes getting people to do windmills, blowing up balloons, those things will encourage them initially to do deep breathing. And I don't know if anyone's ever done laughter yoga. I'm making a fool of myself here, but with laughter yoga, right, you'll find if you actually do, it encourages deep breathing, and I cough ages afterwards because I've moved all that fluid that's just sitting there that I'm not actually aerating my lungs properly when I'm sitting in my desk. So things like that, it's quite incredible. You'll find how much it moves. Hydrotherapy is a great form of exercise in lymphedema. I really think if you've got a patient that can get in a pool, hands down, that's what they should do, especially in Australia, because when you're standing in water, what's happening? The deeper you go, the more pressure there is. So literally just standing in a swimming pool is putting more pressure at your toes than at your hips. So it's like wearing a compression garment made exactly to your shape. If you then walk in the water, you're exercising, pumping those muscles, moving the lymphatics through. And you've also got the rippling of the water over the skin, working on those superficial lymphatics. So compression, check, superficial lymphatics, deep lymphatics with a muscle pump. And it's cooling. If you've got cool water, then that's going to be helpful. So that is the best thing that you can do for edema. Obviously, it's not accessible to all patients. But yeah, try it sometimes. If you've got a day where you've got really bad swelling, get in the swimming pool and see what happens. You'll just be right back where you at the beginning with the fluid down. But really we know that it needs to be cooler temperature, so under 28 degrees. And a lot of hydrotherapy pools are actually warmer than that, so it may not be suitable. So if we come back, the next two things that we still need to talk about are massage and compression. So manual lymphatic drainage, really important to have this done by a qualified lymphedema practitioner. And the reason is that they've been trained, yes, in the lymphatic pathways that we've talked about, but they'll also know what to do when those pathways have been changed. So when someone's had lymph nodes removed, there's no point in draining to that area because there's nothing there. There's no lymph node to take it away. There's nothing to clear the traffic jam. So you need to redirect flow. And you can actually end up taking fluid from one armpit across the centre to the other side and around the back and doing various things. So you really need someone that's been trained in that and knows what to do to vary for different patients, to get around the scar tissue, to get around the fibrosis from radiotherapy and so forth. And then they can certainly advise the patient on how to do it, to tailor it to themselves. There are a lot of people that say they do lymphatic drainage, but it's just important to work out if this person has actually been trained in lymphedema and looking for an accredited practitioner, and I'll show you how to find one of those a bit later. But certainly that's an important way to look at that, and I think any therapist should be able to teach the patient how to do it themselves and for the carer how to do it, because that's going to be so important for maintenance going forward. It's really, massage is a very gentle massage. It's not sort of like one of those deep sort of Swedish ones. It's very it's like patting a cat. And really you're sort of opening up those superficial lymphatics and moving the fluid through, and you actually start centrally and clear back to the middle, and then before you even get down to the foot or down to the hand, you sort of start here and then you go down there and come back up again. So there's certainly a specific way to do it. And it's most of the time massage is best done with compression. Applying compression therapy, so it's really pressure to the limb, and that's going to improve both the venous and the lymphatic flow back. It's really important when applying any pressure to just make sure there's not arterial blockage. So really just an ABI is the simple way to do that, and most people, as long as they've not got peripheral vascular disease, will not have a problem with that and actually be able to take quite a bit of compression. The compression, we looked at the two different phases there. When you look at that first phase of how we actually get it down, it often takes 2 to 4 weeks, depending on the size of the limb. And I know when I was doing training in Germany, some people are there for 2-3 months to try and get that swelling all the way down when you've got someone with a really large limb. But typically most people would be sort of in a 2 to 4 week period, and you're changing the bandages every day. There's newer bandaging systems that allow us to be able to do it every 3 days, and that's been really good for people in rural areas, but essentially that's the concept of treatment to bring that down. And once you've got the swelling down as small as you can go, then you can fit with a compression stocking to maintain that, and that needs to be worn daily. Some patients will wear it 24/7. I wear my compression 24/7 because I know I swell if I take it off for 5 minutes, but other patients do quite well if they just, during the day, wearing their garments and then they take it off at night. A lot of people will do fine with that. But either way, the garments need to be changed every 6 months because the elasticity goes. We all know, like if you've got a tubey grip and after a while there's only so many times you can apply it, the elasticity goes. And so you need to replace it. And most people recommend about 6 monthly. And you need 2 garments at a time because when you're not wearing it, you're washing it and you need to be able to go back and forth. So this is where the cost factor comes in. These are some of the compression systems available. So these are more sort of the traditional short stretch bandage layering system, and this needs to be usually changed daily. Sometimes you can get away with 2 dailies, so sort of every second day, sort of when you're doing an over the weekend sort of treatment, but typically daily. This is sort of the Coban 2 system that you'll see outside a day, and that one's every 3 to 4 days, and that one's been really helpful for people who there's sort of the bandaging can actually be a little bit. The tight is not the word, it's just a little bit more compact, that's what I'm looking for. So they find that, obviously you can see this person's typing with it and it's a little bit more user-friendly and great for people who don't want to come in every day. But again, it's something, this one you can reuse the bandages. Here with the Coban, it's a little bit harder. This is a Velcro compression device, so you can actually help with either the treatment or the maintenance because obviously you can keep tightening it as the swelling comes down. And again, this is the Lymphoedema I was talking about, which actually has a bandage that goes over the top, which again massages at the same time and helps to reduce the swelling. So a lot of really good devices out there. It's the last couple of years has really changed the world of lymphedema, so it's exciting for people like me. And that's just sort of, again, the short stretch bandages, Coban 2, Mobiderm, the compression wraps, there's a number of different types of those. So they're the ones to look at. So if we actually survive the bandaging process and you haven't completely come unwound, and we have days like this is not uncommon, then this is what we hope for. We hope for a good reduction in the swelling, and this is when you can ideally stick a compression garment on someone because we've had such a good result. And these are some of the garment options. This is sort of a more traditional garment option here, but you'll find that we often have complex patients with wounds, and so having zippers, having wraps is much more helpful so you don't have that shearing effect on the skin, so that you don't have movement of dressings, because obviously if you're trying to pull a device on and you've got a dressing there, it's just going to all roll up. So some of these options, these are like little swell spots that you can pop into sort of groin areas, sort of around breast areas where it's very hard to actually compress. I'm sure we've had moments like this when you've looked at your patient and you've only got 2 minutes left of your treatment time, or you're already running 10 minutes late and you've just gone, I've got to get the stocking back on and I don't know how, and this is just pretty impossible. There are devices. There are really good devices available, and they're not too expensive. And so these are just some of those ones available, and I would encourage you to, if you've got a patient that really is struggling, whether they've got arthritis, whether they just can't reach, it's certainly helpful for carers and for the patients to put these on, and for you. Like, I find these really helpful to get a patient dressed quickly. Yeah, again, once you've got it on, you've got to be able to get it off. And I think we've often looked at patients walk out and go, oh God, how's that going to work? Are they going to be able, like, I put it on, can they get it off? So sometimes, I guess what I'm saying here is maybe compression isn't going to work. Like, if you can put someone in compression and say, it looks fantastic, look at that, it's great, this is going to be brilliant. But if they're not going to be able to put it on or take it off, there is no point. It's just, let's be realistic. That's when you need alternative options. And these are some of these treatments that aren't compression. And so low-level laser therapy, this is a handheld device, but there are bigger devices available. It works by, believe it or not, stimulating macrophages to chomp on fibroblasts, like on fibrotic tissue. So it sort of chomps on the fibroblasts, and that's to break down those really thickened fibrotic areas. So when you think about all those wounds that get really firm tissue around, where you think this is just, how can it even, the fluid can't move. This is what you sort of need to break down that tissue. Then we've got options, negative pressure, again, really good at breaking down that scar tissue fibrotic area, and it's working on the opposite of compression bandages. We're actually lifting the surface of the skin. So we're doing negative pressure therapy to lift up that surface there, and when we lift it, what's going to happen? Those little superficial lymphatics are going to get a chance to do their job. So we're opening those ones up and making sure that lymph fluid can move. And this one, an example of this is Physio Touch, and that's, again, fairly new to Australia, but we're seeing a massive improvement with people with radiotherapy fibrotic scars. Next is pneumatic compression pumps. I'm going to come back to that one in a second. Same with kinesiotaping, hold those two, because I think those are particularly useful in some contexts. And I'm just going to mention liposuction. Surgery is available. When you've got that limb that's been full for so long, there's no amount of compression is going to bring it down because it's actually converted to fatty tissue. So you can keep applying bandages again and again, but nothing's going to change. And that's when you're doing that pitting test. If you've still got a dent coming in, then compression is going to work. Doing that bandaging is going to help. If you can't compress it, then you're wasting your time doing the bandaging. You may need to consider something like liposuction. And obviously not all patients are appropriate for it, but there's a clinic at Macquarie University that does that assessment, Macquarie University Hospital rather, that does that assessment and works out if people are appropriate for surgery. So something to think about. But let me come back to these ones. So pneumatic compression pumps. Very good for people immobilised, particularly sort of those people stuck at home in nursing homes. This is quite a good option, and it can be for legs, can be for trunk, arms. It's got little segmented areas where it pumps up, so it actually starts from the top and pumps up, and then it goes the next stage down, pumps lower down the leg, and then pumps back up, and then it comes down to the bottom of the foot and pumps back up. So it's opening and closing these sort of, I guess, balloon chambers and varying the pressure to be able to move the fluid up. And it's really important that people still do massage and deep breathing exercises again. So again, a really real option. These can be hired at the home and they're not that expensive. Obviously to purchase them is much more expensive, but the hiring to see if this is applicable to some patients, really worth a try. Kinesiotaping. This is a little bit similar to the negative pressure therapies in that the tape actually lifts the surface of the skin and allows flow of lymphatics underneath. And you can apply the tape in a specific direction. You can redirect the flow of lymphatics depending on their scar tissue, and it can be left on for several days. So again, a really good option if someone's got okay skin quality in a nursing home, someone that's immobilised, it's a really good option there if they can't tolerate lymphatics. We often use this one in palliative care when someone can't tolerate the pain or they don't want to go through wearing compression stockings, or their limbs are swelling at too fast a rate to actually purchase compression stockings. This at least can slow it down and improve their mobility and comfort. I put here Plan B, because not everyone has access financially or logistically to compression. I don't want you to go straight to Plan B, but really if you've got a little bit of swelling and the wounds are not healing and there's no arterial compromise, you've got to use Tubigrip. Stick it on there, because some compression is better than nothing, and you can do the double layer compression as well. There's even, Tubigrip also has an option which is like a shaped support bandage. That's actually, because most Tubigrip's the same the whole way through, but they've actually got a shaped one going up that way, which is obviously better for legs and things like that. So that's really the best way that you can support that wound environment to heal. Really, you've got to dress it, compress it and elevate it. That's I guess my Plan B take-home message. As long as there's no heart failure or arterial disease blockage, that's fine. You're not going to do harm by doing that. How we doing, people? So I thought I'd just paint a really quick picture of what the lymphedema world looks like. The treatment side of things, these are, the Australasian Lymphology Association is the organisation you go to find a trained lymphedema practitioner, to find out more information, or if you want to find out how you can be trained yourself. And so these are the training organisations. If anyone is actually based in the public hospital system, HETI, they have online modules about lymphedema, really worthwhile doing some really good case studies there to have a look at, and again, links for further information. So if you've got access to that, I would encourage you to have a look at HETI. Then we've got where patients can get support, and really Lymphedema Support Group, that's the hat I wear, and then Cancer Council New South Wales, they've got good options for getting support. And then we've got a whole advocacy arm where we're pushing for funding and exciting things like garments. So, and again, that's the Lymphoedema Action Alliance is where you'll start to see those things. So Australasian Lymphology Association, really easy, www.lymphoedema.org.au, and they are doing research, management, education. All health professionals can be a part of this, including nurses. And we've also got a public register for lymphedema practitioners in Australia and New Zealand. So you can search by postcode and you're looking for this, when you're finding a therapist, you want them to be accredited with this logo. If you would like to find out how to get trained in treating lymphedema, how to do the actual lymphedema bandaging, these guys can sort you out. So Lymphedema Training and Education, and I've actually popped some of their brochures at the back because they're doing a course in November. So a worthwhile thing to look into if you're interested. Again, Lymphedema Stories is a consumer booklet, but it also has a little bit, if you're trying to educate your patient, the beginning parts sort of explain about lymphedema, and then it tells some stories at the back about some difficulty just so they're not feeling alone. That can be intimidating as well, so just picking your patient for that one, but there are some of those booklets at the back too. And the Cancer Council is where if you want to actually get more of those, if you're seeing a lot of patients with lymphedema, then call up Cancer Council to get more of those booklets. This is our patient registry, so if you know someone diagnosed with lymphedema, get them to register because we won't be able to show the government exactly how many people we have unless we have patients registered on this. So I think we're up over 1,000 at the moment, so there's lots of room to grow there if we're aiming for 300,000, but please encourage that. And this is the Lymphedema Action Alliance, which is responsible for lobbying to the government for increased funding and services. And we have a large number of organisations that are working with us, so obviously the breast cancer groups, but also looking ovarian cancer Australia, Country Women's Association, that's been pivotal, YWCA, so all good groups to be involved with. Questions? Am I okay still? Didn't do that very well with time management, did I? Can I answer any questions? Please. Yeah. Okay, so, well, technically, you know, when you sort of, when you go level of the heart, that's what we advise. Anything is better than nothing. I think it's really important though that you're not actually blocking off their groin, because if you're elevating someone and they're in this kind of shape, that's probably doing more harm than good. And we've all seen patients where you go, oh yeah, the fluids come out of their legs, but now it's at the sacrum. So it's, you know, really it's choosing your patient, but certainly for, you know, people who are immobilised and yet making sure that we are getting up. So some is better than nothing, but ideally, obviously, when they're lying flat is the correct amount to get, but then, you know, we're looking at pressure sores and things. So varying it up a little, yeah. That kind of answer it?
Before we take another question, and we will, because you're not off the hook yet.
Okay.
What we need to do is, Matt is our next presenter, but we've got to get his presentation onto the computer. So while we're busy, and you're busy with us, please ignore Monique and Matt, who will be here behind us as they get Matt's presentation loaded on. So they're the distraction, but don't look at them, okay? Now, while I have this dear lady here still, were there any more questions that you have? Because if you don't, I do. But we'd rather hear yours
Please ask
first.
questions. I want your questions.
If someone's on penicillin, what
Yeah. So look, I mean, obviously it depends on how severe their sensitivity is. We end up going to clindamycin though in those people who are truly sensitive. Yeah, that's where we end up going. Good question. All of this you'll see in the ALA antibiotic guidelines. It's actually a really good document. It doesn't just talk about what antibiotics to choose. It's the whole approach to cellulitis and when to massage, when to compress. Because people will say, okay, it's a red hot limb, it's sore. How do I deal with the swelling? Because if I don't treat the swelling, it's still gonna, you know. So it's quite a good guide as to how to approach that.
Any other questions? Because we'd rather hear yours than mine.
Can I ask your view on lymphedema treatment in active phases of cancer?
Yeah, really, really difficult and lots of controversy around that. And it's also a really unethical area to research, as you can imagine. Certainly in palliative, we treat because it's about comfort, isn't it? In those people where it's an active disease because they've got lymphedema because the node's affected, I guess you've got to prioritise for the patient, don't you? And it's having, like with anything in medicine, you sit down and you do a risk-benefit analysis and you sort of say, what is it that the patient needs? If they are so uncomfortable that life is not compatible, then you probably need to move forward with treatment. But certainly there's ways of doing it and still perhaps applying compression, but not spending as much time on the massage. And people would argue that, obviously massaging over lymph nodes and things like that, maybe that's not. And then some of the studies are saying, well, actually, it's going to move anyway. I mean, this is at a microscopic level what's happening with metastatic spread. Is it actually, lymphatics, they're designed to move forward. So whatever we do is not necessarily going to make that much worse. But yeah, a lot of controversy over that. And I would go on a case-by-case basis and you talk about it with the patient. And I think with anything, if you say that we don't know exactly, but this is what we do know, and usually the patient will have made the decision for you.
We've probably got one more question, no, two more, because I'm busting to ask you one as well. But your question, please.
I'm interested to know about your view of managing or the role of compression in cellulitis.
Yeah, so my opinion is if you've got fluid there, the edema gets worse, right? When someone's got cellulitis, the edema gets worse. So trying to move that fluid would be the best to move forward. But it's very uncomfortable. You want to make sure, I'd be making sure that the person's at least, they need to be on treatment. Like you would not treat their cellulitis with compression. Obviously they need to be on antibiotics, and I want to wait till they were sort of at least 24, 48 hours into that treatment. And you'll find they probably aren't going to tolerate compression before that anyway. Most people, if they have their compression garments, they're not going to fit because they're enlarged, so then you're only looking at wrapping there. And so no, I would probably look at adjunct treatments and look at massage, look at some of these other options to moving the fluid in the more short term, but as soon as you possibly can, get that compression back on, 100%.
Can Linda just join me for a moment as well? But while Linda's making her way to the stage...
I'm getting nervous now.
No, don't get nervous, because I've asked you this question before,
okay.
So you know the answer. The thing that I often get asked in regards to lower limb swelling is at what value is using diuretics in the control of that swelling? Mm-hmm. So with somebody with lymphedema of the leg, what is the role of diuretics?
There is no role. Diuretics in the past have been used to treat lymphedema. In fact, we find it actually exacerbates it. So really, you would think any way of moving the fluid, but this is not the correct way. You want to make sure you're moving the fluid through the lymphatics, and sometimes actually by taking away fluid from the sort of intravascular system, you're actually not allowing the lymphatics to work properly. And so we actually find we end up dehydrating the body, but those people with lymphedema actually need to drink more fluid. I mean, I don't want to tip them into heart failure, but they actually need to be, someone that's got a healthy heart, you actually need them to be drinking good amounts of fluid so that they can keep moving forward the lymphatics, so you can encourage the flow. So drinking good amounts of water is more important. Obviously, if you have someone with heart failure, then they are going to need diuretics in their treatment, and that's a really tricky balance. So finding enough that you can. So I mean, I can think of my most famous patient to me anyway, is sort of she really had heart failure and primary lymphedema in both legs, and we had to titrate her diuretics, and because I was compressing her legs, more fluid the load was going on her heart. So we had to give her diuretics because as I was moving the fluid from her legs, we needed to get it off so that it wasn't putting strain on the heart. So, on a weekly basis, we were titrating her diuretic to make sure it was allowing for the fluids. And obviously that's a complex case, but so there is a role in certain patients. But in those people who are purely presenting, who are otherwise healthy with lymphedema, no diuretics.